Today we're going to talk about non-emergency and specialty services and transport, and we'll cover these specifically as they relate to reimbursement and billing. So first, let's cover non-emergent transports. So these are our medical transportation. So these might be within your EMS service, your 911 service. You might also um, provide medical transport, or you might not. So um, typically, private companies provide medical transport. They can be in full ambulances. This also covers wheelchair transport and wheelchair vans. So this is our non-emergency transport. It's anything that's not 911. It's anything that's not critical care. It could be interfacility. But most typically, these are hospital discharges or transports, medical transports uh, to physician appointments and specialty appointments. Now, on the specialty side, we're going above and beyond the 911. We're going above and beyond the medical transport. We've got some specialty transports here. We typically think of these as our critical care transports, and we can transport these patients via ground or air. And through the air, we're going to differentiate between our rotor wing or our helicopters and our fixed wing or our airplanes. Typically, these are hospital based, so our transport systems for these specialty cares. Um, and our providers have an expanded scope of practice. So maybe adding in mechanical ventilation, um, invasive monitoring, central lines, arterial lines, chest tubes, and the like. So for our specialty transport systems, specialty care, you might have a paramedic on board, you might have a nurse on board, you might have a respiratory therapist on board, and then possibly a driver or a pilot where needed. Helicopters might have a nurse and a paramedic with a pilot. Your ground units might have a nurse and a paramedic with a driver. A lot of pediatric units, neonatal units, have paramedics, nurses, and respiratory therapists on board. So a lot of these pediatric teams have respiratory therapists as part of the treatment team. The physical ambulance units are much larger to accommodate a larger crew. At least three providers, or ground. We're talking about a driver with a paramedic and a nurse, or a paramedic and a respiratory therapist, or a nurse and a respiratory therapist, or a couple paramedics or a couple of nurses, depending on what that organization provides. So here we have a WakeMed mobile critical care unit out of Raleigh. Larger, we see the four-door cab. To accommodate this, they can fit two patients in the back, one horizontally, one vertically, or transversely, and so just larger units uh, comparatively. On the helicopter side, this is out of Dartmouth in New Hampshire, or Dartmouth University out of New Hampshire, and again, maybe a paramedic, maybe a nurse, maybe a respiratory therapist. These are our specialty care transport units. A lot of services, again, these are hospital based. This is out of Dartmouth Hitchcock Hospital, out of New Hampshire, and they're going to run both ground and air units. Here we see the Kangaroo Crew out of Texas Children's Hospital, a specialty fixed wing unit, and dedicated to pediatric transport. So just depends on the level of service and the clientele that you're catering to. On the paramedic side, what qualifies you to serve on one of these teams? Well, there are a few certifications out there. These are all through private private companies, private organizations. For paramedics on the critical care side, we have the critical care um, EMTP, CCEMTP through University of Maryland, Baltimore County. They were kind of the first to do this. They're the standard. So you might be able to go through that program. They offer that throughout the country. After you have a handful of years of experience as a paramedic, there's also the CCP certification, critical care paramedic certification through another private organization. They also run, that same organization runs the FPC, the Flight Paramedic Certification Program for flight paramedics. On the pediatric side, also through the University of Maryland, Baltimore County, UMBC, they run this pediatric and neonatal critical care transport certification. All right, so when we're talking about interfacility transports, and we're going to focus on these interfacility transports, let's say hospital to hospital, specialty care, either medical transport or critical care, we need some really specific paperwork. And one of those is paperwork that says that the transport is both necessary and reasonable. So how do we find necessity? Necessity is defined as any other mode of transport will be detrimental to the patient's health. So if we threw the patient in a taxi cab, on the bus, any other transport other than an ambulance, the patient would deteriorate, and that the transport itself is to obtain a medical service. On the reasonable side, how do we define reasonableness? Well, the level of service that we render must match the patient's need. So, my BLS patient with simple nausea, vomiting, or let's just say nausea, doesn't need an IO, doesn't need to be intubated, doesn't need a chest tube, doesn't need mechanical ventilation. So the level of service that I offer must match the need of the patient. If the patient is to go by ambulance, the patient must also be bed confined, and there's a very strict definition of bed confinement. One is unable to get up from the bed without assistance, and the patient is unable to ambulate without assistance, and the patient is unable to sit in a chair or a wheelchair. So to be bed confined, your patient must satisfy all three of these criteria. Can't get up from bed, can't walk, and can't sit in a wheelchair or chair without any assistance. Now, we don't have to define that bed confined ourselves. This is going to be in the form of a necessity form or a physician's certification statement signed by a physician or their delegate. And this declares or states that the patient cannot be transported by any other means other than an ambulance. There are repetitive options. So let's say we've got this patient that goes to dialysis 3 times a week, needs an ambulance to go back and forth to dialysis 3 times a week. We don't need a form every single time we go back and forth and back and forth and back and forth and back and forth. We can have a 30-day or a 60-day physician certification statement saying that this patient must go by ambulance. So as long as we have that PCS on file, our billing to Medicare, Medicaid, or their private insurer will be covered. But just knowing that the bed confinement is defined by the physician or their delegate and is not up to us. Continuing on, and for our paperwork, our interfacility transports, we need some paperwork to satisfy EMTALA, the Emergency Medical Treatment and Active Labor Act from the 1980s. This requires a physician signature from the transferring facility. It requires the name of the receiving physician at the receiving facility, and it requires the names and signature, or well, signature from the transferring nurse, but it requires a name from the receiving nurse at the receiving facility. So, what this um, piece of paperwork does is say that we have a receiving physician. The receiving nurse has received report and knows that the patient is coming, and that the patient is being transferred to a higher level of care. So the patient is being transferred for a specific reason. EMTALA came about in 1986 to prevent what we called patient dumping. So a patient shows up in your emergency department, has no means to pay, and you say, well, we'll just transfer you to the other hospital. And this was a huge problem, came about in Chicago, and the private hospitals in Chicago um, would see a patient who had no means to pay, needed a large amount of services, said, well, you need to go to the county hospital, and would transfer them to the county hospital, and the patient would deteriorate as such with it's basically withholding treatment. So to prevent patient dumping, EMTALA came about in 1986. So any hospital that receives Medicare payments, which is just about every single hospital in the U.S., must provide a medical exam and basic stabilization, regardless of legal status, regardless of ability to pay, and regardless of legal citizenship. With all that, how do we get reimbursed as ambulance services, as EMS agencies? How do we get reimbursed? Well, we are primarily a fee-for-service or under a fee-for-service model where we bill for the services rendered. So we can bill for a response, we can bill for the loaded mileage, sometimes for mileage above that. Sometimes we can bill for disposable supplies. That is in contrast to capitation, where a provider might be paid a flat amount per patient, regardless of what is offered to that patient and what services are provided for that patient. A quick way to think of fee-for-service versus capitation is to think of McDonald's versus a buffet. So you go into McDonald's and you order a cheeseburger and some nuggets and a soda and some fries. You pay for that cheeseburger, and you pay for those nuggets, and you pay for that soda, you pay for those fries. You pay for each one of those items. That's a fee-for-service model. On the capitation side, you pay a flat fee. So you're going to your local buffet, and you pay $10, $12, $15, whatever it is. You pay a certain amount and you get in. And then once you're in, you can use whatever you want. You can eat whatever you want. So that's a capitation model where there's a flat fee, and then you can eat whatever you want. Well, on that fee-for-service side, CMS, or the Centers for Medicare and Medicaid Services, defines a few service levels for us. The first of which is the BLS, Basic Life Support level. So on this level, we can bill when BLS services are rendered, even if a paramedic is part of the crew. So for only offering BLS services, we can bill at a BLS level, even if a paramedic is part of the responding crew. So we have BLS and we have BLS emergency, two different levels. BLS emergency is it's an emergency dispatch. The BLS, the simple BLS level, is scheduled. Once we get into the ALS level, we've got ALS 1 and ALS 1 emergency. Again, The difference between the two is the emergency is an emergent, usually 911 response, while the ALS1, just simple ALS1, is a scheduled, so we're looking at scheduled versus non-scheduled. So ALS1 is there's an ALS assessment and at least one ALS intervention. So you've got a paramedic assessing and at least one ALS paramedic intervention. Then we move into ALS2. So we've got all of that. We've got a paramedic, we've got an assessment, and then we've got at least 3 separate IV medication administrations or one invasive procedure. So this is the highest level that we can bill in the 911 setting, in the emergent setting, without going into critical care. So I've got at least 3 IV medication administrations or one invasive procedure to bill at the ALS2 level. So what is an invasive procedure? So if we have at least one of these, we can bill at the ALS2 level. We look at shocking electricity. We look at some pretty invasive stuff, airway maneuvers, intubation or surgical airways, central lines or arterial lines, decompressions or IOs. If we have at least one of these, then we can bill or we can upgrade from the ALS1 billing level to the ALS2 billing level. The next level of billing is our SCT, or our specialty care transport. For this level, we have an expanded scope of practice. We've talked about that previously. And some states actually do provide or do recognize a critical care certification or specialty care certification. So in North Carolina here, we do not. Even if you've gone through a critical care course, wherever or whatever it may be, North Carolina does not recognize, does not provide any state level certification or license above that of paramedic. And comparing that to Wisconsin here, Wisconsin does. So Wisconsin also, above a paramedic, also recognizes a critical care paramedic, and that has some billing implications. That being that in North Carolina, if we want to bill at the SCT level, we must have a higher level expanded scope of practice practitioner as part of the treatment team in order to bill at the SCT level. So North Carolina does not recognize, legally at least, critical care paramedics, so we must have a nurse or a PA or a physician on board. In Wisconsin, you can have a paramedic, you can have a critical care paramedic on board and bill at the SCT level without a nurse or a PA or a physician. So it depends on your state, but it really has some, like we said, some implications for billing, whether or not your state legally recognizes that critical care status for your paramedics. There's one more billing level that we need to discuss briefly, and that is of paramedic intercept, or PI. This is where we have a non-transport agency, and that agency provides a paramedic that intercepts a BLS ambulance, and the BLS ambulance does not bill, and that paramedic agency provides the ALS support during transport, and this gets a little hairy because there are a number of stipulations here. I'll go down to or back to, let's say, up in New York, outside of Albany. There's Guilderland, and a number of upstate New York towns provide this, but let's talk about Guilderland, New York in particular. Guilderland provided a paramedic on a QRV, and the ambulances were rescue squads, volunteer rescue squads. So the ambulance was BLS EMT staffed, dispatched to a 911 call alongside the paramedic QRV, and the paramedic would provide ALS support in the ambulance if needed. If not, the ambulance would transport the patient BLS to the hospital, and that volunteer rescue squad did not bill. So they were funded by tax subsidies and did not bill. So this would be a PI, a paramedic intercept level billing, where if that paramedic on the QRV were to jump on the ambulance that didn't bill and treat the patient well en route to the hospital, then that paramedic intercept, that town could, that agency could bill at a paramedic intercept level. Okay, so after all of that, after all those BLS and ALS and PI and SCT levels, what does CMS, the Centers for Medicare and Medicaid Services, allow us for reimbursement? So our base rate, $229.91. That is super specific, but that's what we get from CMS. That's our base rate. And then we can add on our RVUs, our relative value units. We'll hit that here in a minute. And that's just an adjustment for the level service that we have provided, whether it's BLS or ALS1 or ALS2, PI or SCT. We can also add on mileage, and our mileage is determined based on whether we're an urban service or a rural service. We have urban, there we go, urban mileage or rural mileage. And then there's a geographic regional cost adjustment, which we won't really get into, but these all factor into our reimbursement rates. But our base rate, let's remember, is $229.91, which is typically below our per transport cost. On top of our base rate, we can adjust for our relative value units, or our RVUs. We'll start with the BLS, just the basic BLS rate, and an RVU of 1. So remember, our base rate is $229.91 from CMS. Above that, for BLS emergency through ALS1s and ALS2 and SCT and PIs, our RVUs increase, and all we do is multiply the base rate by the RVU to get the base rate for that service level. So if we are providing an ALS1 emergency, which is fairly typical, I have our base rate of $229.91, but our relative value unit, our RVU for ALS1 emergency, is 1.90. So if we multiply the two, we get $435.50. So that becomes our base rate for our ALS1 emergency response level. If we're going through our SCT, which is the highest, which is pretty important. So if we're in North Carolina, paramedics are not legally recognized as critical care. So we need to make sure that there is another provider, say a nurse on board, or a PA or a physician. Our RVU goes up to 3.25. So our base rate multiplied by that, our base rate for an SCT transport goes up to $744. That's pretty significant. So we need to take these RVUs into account when documenting. For mileage, we can bill for mileage, and these are loaded miles. So scene to hospital we can bill for. CMS also allows us to bill for mileage from the hospital back to your base station. So if your organization, if your agency is not prioritizing, is not making you document mileage from the hospital back to your station, you might want to ask your manager, because CMS does allow us to bill not only for loaded miles, but for mileage from the hospital back to our home station. But what are our mileage rates? What is our reimbursement per mile? And this is from CMS, Centers for Medicare and Medicaid Services, and it's worth noting that most private insurers follow CMS policy. So mileage rates from CMS, about $7 per mile in the urban categorization. On the rural side, they split out miles 1 through 17, and for rural agencies, miles 1 through 17, up to 17 miles, reimbursed at just under $11 per mile. Well, what happens if we have multiple patients on our transport? Sometimes we take more than one patient. So how do we get reimbursed for those? So again, this is CMS policy for multiple patients. We get 75% of the base rate for each patient. So we don't get 100% for each patient, get 75%, and then we get 50% of the mileage for each patient. So that makes sense. If we're taking multiple patients, usually taking two patients. In some cases, we're taking more than two patients, but most of the time, multiple patients, it's two. We get 50% of the mileage reimbursement, and we get 75% of the base rate for each of those patients. As always, if you have any questions, comments, concerns, or cuss words, please let us know.